Thank you for joining us for the next session, Down Syndrome, Birth and Beyond. I'm pleased to introduce Dr. Dannah Raz she's a developmental pediatrician and director of the Pediatric Down Syndrome Clinic at Phoenix Children's. She does have a disclosure for Illumina Genetics. She was a former advisory board member in 2021, but there will be no development of her slides by a commercial entity. Please reference your screen for the continuing education unit accreditation and disclosure statements, as well as the continuing education unit tab in the attendee website. And I'd also like to direct you to the attendee website to reference Dr. Dannah Raz's full bio as well. And you can see her learning objectives up on the screen. And if you're ready to begin, I'm pleased to welcome Dr. Dannah Raz.
Dannah, you're muted.
Thank you. Okay. Thank you very much. I'm very excited to be here to talk to everybody about Down syndrome. It is a wonderful passion of mine to be able to care for these people, and I'm excited to share this with you. So as stated, these will be the learning objectives for this session: to implement healthcare guidelines for children with Down syndrome within a practice, and to create a differential diagnosis when behavioral concerns arise for a child with Down syndrome. Again, my disclosures. So Down syndrome is the most common chromosomal condition diagnosed in the United States. It's approximately 1 in 800 to 1,000 live births, and approximately 400,000 people with Down syndrome are living in the United States. Down syndrome is associated with increasing maternal age, which would be 35 years and older. The majority of babies with Down syndrome are, however, born to those that are less than 35 years of age. So I really want to highlight that individuals with Down syndrome attend school, they do work in our community, they participate in decision making, they have and can create meaningful relationships, they vote, and they contribute so wonderfully and beautifully to our society. And as such, it's really important for us to use preferred language for people with Down syndrome. So we use down, we don't use down. So there's no apostrophe when referring to a person with Down syndrome, it is Down syndrome. And then we use people first language. So as you heard me say, it's a person with Down syndrome, a child with Down syndrome. It is not a Down syndrome child. We avoid using terms such as Down's child, he is Downs, or people have Down syndrome. And this is terminology that has no longer in use, which would be mental retardation. Instead, we use a person has intellectual or cognitive disability. So one of the primary objectives of this lecture is to go through the health supervision guidelines. So in May 2022, AAP released the most up-to-date healthcare guidelines for children and adolescents with Down syndrome, whereas the last update was in 2011. These are age-based recommendations with medical and community recommendations as part of it. So the updated guidelines, so what is the same? The same is the frequency of obtaining a hearing screen. Atlantoaxial instability recommendations are the same, which I will go over a little bit later. Thyroid screening and celiac screening, all of which I'll detail throughout this presentation. What's new is information about discussing the diagnosis with family. This is an important piece to add to the healthcare guidelines, as it has been found to be really important to the family as they are discovering this new diagnosis for their loved one. New information about ordering CBCs, checking iron stores, growth charts, visions. They are now adding that these can be done with photo screening. A sleep study, there's been updates to the time frame, dermatologic conditions, gynecological care, and safety, and all of this we will go throughout the presentation. And what's really nice is healthychildren.org has updated guidelines for parents. These have been in progress, but parents can access this to be able to see what the guidelines are for their loved one. So common medical concerns and problems that occur in individuals with Down syndrome are many times we get hearing problems. These can be conductive hearing losses or sensorineural hearing losses. They have vision problems such as nystagmus, glaucoma, frequently can have nasolacrimal duct obstruction and cataracts, which is highlighting the importance of getting both hearing and vision screening regularly. Many individuals with Down syndrome have obstructive sleep apnea. They can have otitis media with effusion, high incidence of congenital heart disease, feeding difficulties, frequent respiratory infections, dermatologic concerns. They can have hypodontia and delayed tooth eruption. So oftentimes it's important to provide anticipatory guidance for families that this will be delayed. Thyroid disease can be common, seizures, gastrointestinal atresias can occur, hematologic problems, which the percent varies by the problem, but we can see anemia, we can see iron deficiency, transient abnormal myelopoiesis, which I will go over, as well as leukemia. People with Down syndrome can have autoimmune conditions, symptomatic atlantoaxial instability, which we'll review, autism, and Hirschsprung disease. So the guidelines are really intended to be able to make sure that we are monitoring for all of these in children with and adolescents with Down syndrome. So just to review the genetics of Down syndrome. So Down syndrome, there are 3 different types that we can see. So trisomy 21 non-disjunction is the most common. It affects about 95% of people with Down syndrome. This is where each cell in the body has an extra or third copy of chromosome 21. Then there's translocation, which is about 3 to 4% of people with Down syndrome. It can be inherited about a quarter of the time when a parent has a balanced translocation. And this occurs when a part of the 21st chromosome attaches to another chromosome. So there's a normal copy of the 21st chromosome as it is, but then there's extra material attached to another chromosome where we get the trisomy 21. And then there's a mosaicism. So mosaicism is about 1 to 10% of people with Down syndrome. It occurs sporadically, so it is not inherited. And there's an extra copy of the 21st chromosome in only some of the body cells. So typically, trisomy 21 is first picked up through prenatal screening, where it is identified that there is a chance that the baby may have trisomy 21. This can be through the first trimester screening, where it's a combination of factors of maternal age, a nuchal translucency ultrasound, and various lab measures. And then there's a second trimester screen, which is also known as the quad screen, which takes into account maternal age, maternal beta HCG, unconjugated estradiol, alpha fetoprotein, and inhibin levels. And what is coming to be a more common screening is a cell-free DNA, which detects the chromosomes of the baby apart from the mother, which can then detect the chance of an extra 21st chromosome. A confirmation diagnosis is done either through a chorionic villus sampling or amniocentesis. And then when the diagnosis is either confirmed or the chance is identified as being high, it may be warranted to do further testing, such as a fetal echocardiogram, ultrasound evaluation of the GI tract to determine if there's any atresias present. And a parent and the parents, the people that are going to be giving birth, may want to have a consultation prenatally with a geneticist or a developmental pediatrician to talk about what they can expect once their baby's born. And then we confirm the diagnosis postnatally, most specifically if that prenatal confirmation testing is not done. So first and foremost, we want to have a physical examination to identify the concern for trisomy 21. And in a moment, we will go over the phenotype or what can be identified through physical examination. And then a chromosome evaluation is done. There can be there's really 2 options for this, or a fluorescent in situ hybridization, which would give us fast results, but would really only tell us if there is a trisomy 21, and a karyotype would tell more about the details of that, such as if it is translocation or mosaicism. So for the phenotype, it can be broad. So there are a variety of what a child with Down syndrome can have, and some may or may not have these. So many times we do see hypotonia, low muscle tone in these babies with Down syndrome. Brachycephalic head, which would be a wide but symmetric head. They have epicanthal folds. We can see a flat nasal bridge, upward slanting palpebral fissures, brush field spots in their eyes, a small mouth, small ears. They can also be low set and posteriorly rotated. They may have excessive skin at the nape of their neck, a single palmar crease, which if you can see my pointer is right here in this, this picture. They may have a short fifth finger with clinodactyly and wide spacing, which you can see here. A deep plantar groove between the first and second toes, and they may have a large and slightly protruding tongue. So once the diagnosis is confirmed, it's really important for a provider to be competent and comfortable in giving the diagnosis. And Skotko et al. Did a survey where they looked through a database to understand how to best deliver the diagnosis to parents of a baby with Down syndrome. And what they found is, first and foremost, parents, of course, want to be congratulated on the birth of their child. They're celebrating this birth. And we want to make sure to refer to the baby by the baby's name if they have so chosen the name. Parents want to be known as soon as possible that there is the chance or there is the confirmation of the diagnosis. And when this conversation is happening, if both parents are present, we'd want to have them together, or if not, then we would want the parent that is present to identify a support person that would be available. It's important to use the family's preferred language. So if it is not a language that the provider is fluent in, to then obtain a medical interpreter so that the parents can fully understand what is being told to them and to be able to feel comfortable asking questions. This should occur in a private setting. So if the family is in a shared room with other people, then to make sure that there is a private room for this conversation to be held. And ideally, this should be done in person by a healthcare professional, and families identified as the preferred healthcare professionals is to be ones that have been part of the care since the beginning, or the identified pediatrician. It is important to provide balanced and accurate and up-to-date information and discuss positive aspects and potential challenges related to Down syndrome. So again, really having that balance. Really using neutral language and avoiding "I'm sorry" or "I have bad news," and really just talking about what the family should be anticipating and looking forward to. Using sensitive language and avoiding outdated terminology, as we discussed earlier in this presentation, and allowing for silence and tears, offer family time alone to really be able to process this new diagnosis. And again, we highlight that it's balanced, but having a new diagnosis is really important for families to be able to process together. We want to validate their feelings, give empathetic responses, and provide information. And it's really important to highlight that individuals with Down syndrome do report that they are happy with their lives and share similar hopes and dreams as people without Down syndrome, and that family members feel that their outlook on life is more positive and better because of their family member with Down syndrome. So postnatal care in the nursery or in the NICU, wherever the baby is, the healthcare guidelines is very specific in kind of what should be done or what should be monitored for. So an echocardiogram should be performed once the baby's born. If a fetal echocardiogram was already done and they were in the care of a cardiologist, it is important to go by their what they would want to be done once the baby's born. Monitor feeding, so looking for possible signs of aspiration, such as slow feeding, choking with feeds, slow weight gain, respiratory problems, desaturation with feeds that would warrant a swallow study. So, and babies with Down syndrome can have success with breastfeeding. So there's no reason for a family who is motivated to feed their baby with breast milk should not be encouraged to do so. A red reflex examination to check for cataracts. Newborn hearing screen, which is typically done on all babies, but making sure that gets done on these babies with Down syndrome. A car seat evaluation, to make sure they're able to maintain their oxygen saturation. That the low muscle tone can sometimes impact that. We want to monitor stooling to make sure we're not missing anything such as an anal stenosis or Hirschsprung disease. Monitor breathing, which if we're finding any stridor, wheezing, or noisy breathing would warrant a referral to assess for airway abnormalities. A complete blood count with differential is recommended by day of life 3 to check for any abnormalities, which we'll be going over in just a moment. And then the newborn screening. So here in Arizona, a thyroid stimulating hormone, the TSH is part of our newborn screenings, but this may not be the same throughout in other states. So if it's not part of the newborn screening, then additionally making sure to add a TSH as part of the initial blood work. So transient abnormal myelopoiesis is one of the reasons why we check a CBC at birth, at the time of birth in these babies. It was formerly called transient myeloproliferative disorder. So it's clonal myeloproliferation, which can present as peripheral leukocytosis, variable pancytopenia, and blasts on peripheral smear. The clinical presentation can be variable, where they can present with pericardial and pleural effusions, hepatosplenomegaly, jaundice, rash. But for the most part, most cases regress spontaneously, however, not all, and some may require chemotherapy. Those that do have more severe disease, there is an increased risk of death within the first 6 months, and those with the diagnosis do have an increased risk of developing leukemia by 4 years of age. So a consultation with hematology oncology would be warranted. And then additionally, prior to discharge, we do recommend referral to early intervention services. So these occur in all states. And certainly if we can get that started before the family goes home so that they can be contacted once they're home. Provide family community resources. So Gigi's Playhouse is a resource that is present in various states. We have local Down syndrome groups here, which are up here on my page. And then there's also national groups such as the Global Down Syndrome Foundation. We want to discuss with the families what family and community supports they have and provide them resources if they need any more. Discussing avoidance of excessive neck extension or flexion of the neck due to that instability. They are at increased risk of respiratory infection, so some may qualify for synergies for RSV protection. And then the discussion of complementary treatments is specifically to kind of advise families that these are out there. You will read about them. Families are doing their research. They're part of groups, and that there are those that are safe and those that are dangerous. And so it's important to bring this up so that you then become a resource to family once they're hearing about those, to say, okay, I'm going to then talk to my provider about which are the ones that would be safe for me to explore and which ones I should not. So part of the healthcare guidelines is it's recommended at each appointment, so each well check, each visit, to support the family, look into what supports they have, discuss age-specific Down syndrome related medical and developmental concerns, see if there's any financial and medical support programs that the family can access, discussing injury and abuse prevention and nutrition and activity. In 2015, there were published new growth curves for individuals with Down syndrome that we recommend using at well checks to monitor weight. For development and cognition, so developmental delay is quite common in kids with Down syndrome. We can see global developmental delay or development in specific delays in specific areas of their development, such as motor skills, speech language, and adaptive skills. This is the most common genetic form of intellectual disability, and they can range from mild to severe. Social skills are usually a strength of people with Down syndrome. They really do have wonderful social skills, but we also want to be on the lookout for autism spectrum disorder, which can also occur. And when it occurs, we want to make sure that we are considering both the developmental and cognitive profile of the child and where their social skills are at. If a child has an intellectual disability, then we want to make sure that we are estimating their social skills to be closer to where their cognitive functioning is. Children with Down syndrome and autism do tend to have lower cognitive abilities than Down syndrome or autism alone. But overall, there autism symptoms appear to be less severe, both the social effect, social communication skills, and repetitive behaviors. But overall, the social effect was more impaired than Down syndrome alone. Interestingly, this study found that repetitive behaviors that are part of the diagnostic criteria for autism can also be seen in children with Down syndrome who do not have autism. So it's really looking into those social skills. Further research is needed to really better understand this dual diagnosis, not only in how to diagnose it, but how to really pick it up. So again, as I stated earlier, the guidelines are broken down by age, so I'll go through these as well. So between 1 month to a year when they're seen, it's important to review genetic testing, making sure that was ordered, and if it wasn't, then make sure it then gets completed. And sometimes if a FISH was done at birth, then a family might want to order a karyotype to identify translocation or mosaicism as part of the diagnosis. We want to monitor weight and follow growth trends, checking otitis media for otitis media and hearing. If the newborn hearing screen was passed, so if the baby passed their newborn hearing screen, then they need to be rescreened at 6 months. And if not, they need to be referred for further testing. So for the vision, referring to the pediatric ophthalmologist at 6 months or doing the photo screening, and then lacrimal duct obstruction is common again and should be referred for evaluation if not resolved by 9 to 12 months. For sleeping, checking on how the sleep is and reviewing for signs and symptoms of obstructive sleep apnea, which can present in infancy, and monitor feeding. Again, monitoring for signs and symptoms of aspiration and obtaining a swallow study, which is MBS, if needed. Again, the discussion of cervical spine positioning. So thyroid, so reviewing those newborn thyroid results, which could be on the newborn screening, and then repeating the thyroid test at 6 months and 12 months. A CBC should be obtained at 1 year unless they're followed by hematology, and it's recommended sooner. And an iron storage level is recommended too. So it could be a ferritin with a CRP or an iron and TIBC. And then for infants with a cardiac defect, monitoring for signs of cardiac failure, such as tachypnea, feeding difficulties, and poor waking. Common skin findings can be cirrhosis, thyroid, so it's dry skin, so you want to check the thyroid, cutis marmorata, which you can see here in this picture is kind of that lacy pattern of the skin, alopecia areata, vitiligo, folliculitis, and keratosis pilaris are pretty common. Again, anticipatory guidance, providing resources, making sure they're plugged into early intervention. And I think that the real strength of these guidelines is really putting an emphasis on supporting the families and getting the resources in the community. At 1 to 5 years of age, so we're moving towards those CBC and iron studies annually, audiology after 6 months until bilateral ear-specific testing is normal. And then at that point, we can proceed with behavioral screening, visions using photo screening. A TSH should occur at 1 year and annually unless abnormal, then should occur according to the endocrinology recommendations. Monitor for signs and symptoms of atlantoaxial instability, which I'll go into further in just a moment. Celiac screening, so it's a screening, so there's no interval in which it should be obtained. It should be obtained based on symptoms. So if a child has diarrhea, protracted constipation, their growth, their weight, their growth is slow, or they have a failure to thrive that's not otherwise explained, anemia, abdominal pain, or bloating, it would be warranted to check that. Again, monitoring sleep. So we want to monitor for signs and symptoms of obstructive sleep apnea, such as snoring, open mouth breathing, apneic events. And if it has not been identified, then the recommendation is to obtain a routine sleep study between 3 to 4 years of age. We want to make sure they have appropriate cardiology follow-up if warranted, and a testicular examination. So overall, there's a decreased risk of solid tumors in Down syndrome, except for testicular cancer. So as part of the well checks, it is important to just keep monitor for that. So atlantoaxial instability is increased mobility of C2 related to C1. It's symptomatic in about 1 to 2% of people with Down syndrome. It can present with a variety of symptoms: neck pain, new onset torticollis, weakness, spasticity or change in muscle tone, gait difficulties, hyperreflexia, change in bowel or bladder function, or other signs of myelopathy. And So when we start to consider doing x-rays is 3 years of age or older is when we're seeing that bone formation where we can get an accurate radiograph assessment. There used to be recommendations prior to 2011 where it was recommended to get a routine neck x-rays, but that is no longer the recommendation, which is consistent with those guidelines in 2011, where it's really based on symptoms. We do advise parents that contact sports such as football, gymnastics places them at higher risk of injury, and we want to avoid trampoline use unless it's part of a structured program with adequate supervision. We do discuss precautions on excessive flexion or extension with surgeries, procedures, and radiographs. And then for those that are symptomatic, if instability is noted in neutral position, we want to refer to neurosurgery. So 1 to 5, I'm not going to go through all these in the detail again, because some of them are repetitive, but we want to continue to monitor development, monitor for any behavioral developmental concerns such as autism, ADHD, make sure they're receiving therapies and transitioning to preschool at 3 years of age. Again, monitoring growth. And as kids get older, then we start to get concerned about increasing BMIs. So we're monitoring for that. And again, these regular CBC thyroid studies as well. As kids get older, then we want to start to focus on puberty, transition to middle school, those social aspects, and how parents can help their child navigate that, as well as safety in the community. So safety with strangers, safety with peers, things like that. And then for 12 to 21 years of age, again, the healthcare guidelines, the medical guidelines are very similar. Now we're starting to want to monitor for mitral valve disease. But then we're starting to talk about transition planning. So transition into the community, talking with the families, helping guide them through guardianship, power of attorney, medical decision-making, what would be right for them and their family, medical transition, school support, so they are supported through their 21st birthday, and then again, safety, sexual health, and hygiene. And I just wanted to talk about, so there is a diagnosis that's been, it's not new, but there's a lot more new information that we know about it. It's called the Down syndrome regression disorder. It affects adolescents to young adults, where we're seeing loss of previously acquired developmental skills in an individual. There's thought to possibly have an autoimmune component, and psychological stress is thought to be a trigger, although there is ongoing research to identify what is the cause and the best treatment. We can see it as a subacute phase followed by a chronic phase, and it is a clinical diagnosis. There are recommendations for workup, but the symptoms can be heterogeneous, whereas we can see altered mental status, cognitive decline, developmental regression with or without new onset features that are concerning for, that are similar to a person with autism, such as social withdrawal, difficulty with activities of daily living, rigidity around routine changes, decreased eye contact. They may have new onset neurological defects or seizures. These autism features that were not previously present may start to become more present. A movement disorder is really key to be included in the symptom cluster. Again, seizures, insomnia, psychiatric symptoms, anxiety, depression, delusions, hallucinations, and new onset language deficits. So recommendations for diagnosis are that the new onset, it has to be new onset of symptoms within 12 weeks. If more than 3 symptom clusters with the addition of movement disorder is present, it's possible Down syndrome regression disorder. And if more than 6, it's a probable diagnosis. Again, we want to make sure we're not missing anything medically, like obstructive sleep apnea, hypothyroidism, celiac disease, and untreated anxiety, depression, moya, which is a narrowing or occlusion of carotid artery. And a workup would be a brain MRI to make sure there's no abnormalities, blood tests looking for any abnormalities there that could point to a reason for the regression. A lumbar puncture is recommended and a routine EEG. And then Santoro et al. Really delineated in their recent work other workup that would be clinically indicated based on the diagnosis that would be suspected. So I did have a video that we can include about a family story through getting their child's diagnosis and what that's meant for them. So I encourage you all to look at that. It's a really wonderful story. But now I'll stop to take questions.
Sorry, there's my video. So the first question is from Sarah Brettel, and she wants to know if she can use, and it's also from others, if they can use some of your excellent slides and graphics when counseling families with Down syndrome.
Oh, yes, absolutely. Thank you.
Great. The next question is from Susan Owens, and she wants to know, when some types of cells have trisomy and some don't, are there certain cell types that seem more susceptible, and has it been determined why that difference exists?
You know, I don't really know the answer to that, but that is an excellent question, and I can look in and see if there's any research on that, but thank you. That's an excellent question.
Okay. And the next question is, if a child with Down syndrome experiences a regression, either developmentally or behaviorally or medically, what should a parent or a primary care physician do next?
So, you know, what I typically do is if when I have a child that has a regression, I do get an MRI, a brain MRI, to make sure there's nothing there that could be contributing. I do a workup. It's, you know, metabolic autoimmune workup that I kind of delineated in that last slide, and that Santoro et al. Paper really kind of outlines it further. If a provider isn't so comfortable, there are, you know, movement disorder specialists and neuroimmunologists that may be comfortable pursuing that workup, or if they do have a Down syndrome clinic in their area, I certainly recommend that either the pediatrician reaching out to the specialist within that Down syndrome clinic, or referring their family, or if the family would be part of that clinic, then reaching out to them as well.
Great. Are individuals with Down syndrome at higher risk for autism spectrum disorder? And can you please share the reference or updated guidelines?
Yes, yeah, I will. There are no necessarily guidelines as far as when to screen. You know, we're really doing the screening kind of like the general population. So there's the guidelines and what tool to use. There's really a lot of research that is looking into that. But yes, there is higher risk of autism spectrum disorder with people with Down syndrome. But again, it's, you know, it's sometimes it can be hard to really piece apart what might be their cognitive delay, where their social skills look delayed, but they're actually more in line with the child's cognitive skills. And so that's where getting, you know, either a psychological evaluation where someone can do intellectual cognitive testing at the same time, or going to their Down syndrome specialist may be able to help piece that apart.
And then, is the phenotype of Down syndrome different for those with mosaic trisomy 21?
It can and it cannot be. So it can be. So it is felt that some people with mosaicism may not have the full phenotypic features, but there are children with mosaicism, or people with Down syndrome mosaicism, that do have pretty classic phenotype. So it's a yes and a no.
Okay. If a child with Down syndrome experiences a regression, either, well, we already did that one. Sorry, I'm scrolling through the questions here. I think that one got put in there twice. Okay. Is funding available for rural families to access Down syndrome clinics?
There is actually. There are resources. I can pull those out and share them with MSRGN to kind of share that. But it would be based more on the state and where your local Down syndrome clinic is. But I know that there are funds either locally or nationally to be able to support families in transportation and getting to them. And I think now, you know, post-COVID, I think the one of the things that came out of post-COVID is telehealth and the ability for us to provide telehealth. And so if transportation is an issue, I definitely would recommend if looking into whether or not that clinic would be able to provide telehealth services as well.
Okay. And what entity formulates the guidelines recommendations for Down syndrome that you've discussed today? Is it American Academy of Pediatrics or an agency specific to Down syndrome?
American Academy of Pediatrics. There's a Down syndrome medical interest group, and it's a group of providers, specialists, coordinator staff, just medical people in the medical world of Down syndrome who really have a strong interest or take care of people with Down syndrome. And those are the people that really had a strong input into those guidelines.
Okay. Can you expand a bit more on the metabolic evaluation of the regression syndrome before you say it is the Down syndrome associated syndrome?
So what I'm hearing that is maybe what we do. So the workup would include looking for, inborn errors in metabolism that would point to a more, a specific diagnosis that would be causing the regression, rather than this more broad, more clinical based diagnosis of this Down syndrome regression syndrome. Something that, of course, identifying a very specific treatable cause of the regression.
Okay. And any thoughts about CRISPR models toward treatment potential for Down syndrome?
So I can't really speak to that. That is definitely not an area that I'm very well versed in, and kind of that genetic research of it. I don't know if they're the person that asked this question is specifically speaking towards treatment of regression, but I wouldn't be able to speak to that.
Okay. And if a patient was diagnosed via amnio on karyotype was completed, why is it necessary to repeat it? Typically, we order FISH and they look at 50 cells, then they reflex to karyotype.
Yeah, sorry, no, it would not be necessary to complete it if it was confirmed through an amniocentesis.
And then as a geneticist, do we still have a role in Down syndrome? Seems we don't get many consults as neonatologists feel comfortable, as do primary care physicians.
Yeah, I do think there is still a role. We have here at Phoenix Children's, we have a geneticist who does see these kids from time to time, and I think it's a variety of reasons, right? It's one, if the provider that they're seeing is comfortable discussing, the diagnosis, ordering the testing. Certainly, if translocation comes up, that is a very important role for our geneticists to be able to help counsel the family on family planning and risk for another child or chance for another child, and what that means for the family. But families here, some of them really do like having that input and being able to have that genetics perspective of the diagnosis. So I think it can be variable based on the provider that they're seeing and the family's preference and the information that they've gotten so far. So yes, we still do love having the geneticist part of our kind of cohort of people that see our patients. It just can be a little bit variable.
Could you potentially rephrase your point about breastfeeding infants and Down syndrome?
So I think that there can be some, confusion about, with the baby's low muscle tone, whether or not they whether or not families who really want to breastfeed, if that can happen. And I think, as a society, we're understanding more about the differences that parents can choose for feeding their babies. So my point was really to say that if that's what the family, if that is a family's goal, is to have a breastfeeding relationship with their child, with the baby, then we should provide them the resources to do so, instead of discouraging them because the baby is low muscle tone, or maybe they may not be successful, or other kids haven't been, because there are very successful situations where babies with Down syndrome breastfeed for as long as the parents want to. So providing lactation consultation if needed, and just giving them all the resources to make that relationship successful. I hope that was what they were looking for.
I think so. And what are your preferred resources available to help parents and patients navigate puberty in those with Down syndrome?
So so one of my favorite resources is the Vanderbilt Healthy Bodies Toolkit. So there's a boy version and a girl version currently as it is. And so this is a really nice resource for family of children with any different abilities to navigate talking to their child about puberty, hygiene, relationships with others. I think it's really good. Autism Speaks has a toolkit, which I think can be applicable for a family who has a child with Down syndrome that not necessarily has autism. And then there is a published book about puberty and relationships for people with Down syndrome that I believe you can find on Amazon, and I can publish that name of it. I think it was in one of my slides, actually.
Okay, and we have about less than a minute left. So are there cytogenic differences in individuals with Down syndrome regression?
So I don't know if I can speak to it fully, but there are thought to be some potential, autoimmune differences. So that's why a lumbar puncture is recommended to look for NMDA receptors and various autoimmune functioning that can be affecting it. So that is postulated to be part of it, but it isn't necessarily a confirmed cause, if that makes sense. And so again, that's why psychological, like any trigger, a stressor could be part of it where that blood work is not present. But as as a community, a research community is looking into this, they're exploring, some of these kids are responding to IVIG, for instance. So, that points to an immune process. And so it's really a part of understanding what it is so we can best know how to treat these kids.
Okay. There is one more question, but we're at time. I guess I'll read the question, but are you seeing a decreased incidence of live birth of babies with Down syndrome due to advancements in prenatal screening, like the cfDNA you mentioned?
I would say not necessarily. There are places that have, like Iceland, but here not necessarily.
Okay. Well, thank you, Dr. Dannah Raz.